When I had my aortic dissection, I was 33 years old. I was healthy and fit. I didn't have any risk factors for anybody to even think that this was going to happen to me, and it did. About 22 hours after I had my second daughter, I suffered an aortic dissection. I was in the labor and delivery ward still, and I felt a severe onset of back pain. It started at my neck, it traveled down my spine to my tailbone. I had a wave of pain across my entire abdomen, and then it just hit me in the chest, and I just felt like I was having a heart attack. That was the only way I knew how to express it. I immediately called the nurse and said, I need somebody to come in here now, to which their response was, I'll be there in a few minutes. And I said, no, I need you to come in here right now. Something is very wrong. And I felt that impending doom. I knew that something was terribly wrong. So then when a doctor came in, they were able to ask me some questions about my symptoms, and I was explaining how it was migratory. They said, I said it felt like I was having a heart attack, and he said, well, you're a little young for that.
Aortic dissection in pregnancy is a very rare event. However, it's very catastrophic for the mother and for the baby because there is very high morbidity, meaning that they can have complications and problems for the rest of their life from this. And there's also a high risk of death to the mother and to the baby. Some studies have said that potentially that risk is as high as 50% for a baby and 30% for a mother. Aortic dissection in pregnancy is so rare that a lot of physicians will probably never even see this in their career. And so I think it's very hard for them to recognize that this would be something that could happen to a pregnant woman.
I had just gotten out of the hospital for 24 hours. I was out 3 days after she was born, and I was eating dinner and felt pain in my jaw. And I remember thinking to myself, maybe it was because I was just hungry from being in the hospital for a couple days. And then all of a sudden, pain shot down my spine like acid burning its way down into my stomach, and then it started to burn. And I remember I shot up out of the couch into my husband's arms, and he told me, I don't remember, he said, you told me, I think something's wrong, we need to go to the emergency room. And then in my fashion, I decided to sit to see if it would go away, lay to see if it would go away, stand to see if it would go away. It didn't go away. It was burning in my stomach, and then my left leg started to go numb. I heard it was a type 1 or type A ascending dissection needing emergency life-saving surgery. And at that point, I thought the aorta was your heart. I had no idea what an aorta was. And at that point, they had only done the chest x-ray. So I didn't know about the descending dissection or the other aneurysm, as I had an ascending aneurysm as well.
Well, aortic dissection is where the main blood vessel in our body, the aorta, tears. And the aorta is made up of layers of material, proteins, elastin, collagen, kind of like plywood. And if the inner layers tear, you can get blood flow in between the layers. And that's what a dissection is. That can block off some of the side branches on the aorta. And some of those side branches supply your brain or your kidneys or your legs. So you can have trouble with blood flow to those organs, which can cause life-threatening problems. A type A dissection involves the ascending aorta, which is always treated surgically, at least with our current technology. Type B dissection involves generally the descending aorta, just beyond the arch, just beyond where the vessels come off that supply your brain. Well, when a doctor says it's a complicated type B dissection, that means that there's some sort of blood flow problem to the organs in the legs or the intestines, kidneys, liver, or impending rupture, unrelenting pain with proper blood pressure control. Complication is doctors speak for we need to do something like a stent or something to deal with this. An uncomplicated type B is one where blood pressure control has really alleviated the problem, and the blood flow has been reestablished to all the organs, and we're not in pain, we're not worried about impending rupture. They can be easily confused, and it can be difficult to diagnose. That's why it's important to get a CT scan quickly. If they don't do a CT scan, it can be missed, and it has been missed in the past with devastating consequences. The typical signs and symptoms usually involve the abrupt onset of pain for an acute dissection. And classically, it's pain that deep in the chest, it radiates between the shoulder blades. However, an ascending dissection generally involves severe chest pain up higher in the chest, radiating between the shoulder blades. And many times it can affect how the heart is working, so your blood pressure might be dropping. It's more likely to affect blood flow to the brain, so you could have more neurologic problems with a type A dissection. Type B dissection, you would have the chest pain, but wouldn't have the blood pressure problems due to heart effects or neurologic problems. You'd have belly pain, leg problems, that sort of thing.
The number one sign or symptom of an aortic dissection is that pain. So the dissections can start at two places. One place is in the aorta, right where it comes out of the heart. And if the dissection starts there, it tends to be chest pain. That chest pain is sudden onset. It's typically very severe, like people know there's something wrong, and it can be a sharp or even a tearing-like pain. Now, the other place that dissections start are at the right where the aorta is like a candy cane. It goes up and then goes down the back, and it can start right at the place in the aorta where it goes down the back. And the dissections there tend to cause more back pain. And so they can come in with acute chest pain or back pain or even a pain in their stomach if the dissection goes all the way down their aorta, which it can, because like a run in the stocking, it can keep going as if it wants to. It's just, just by chance where it ends up ending. So they can be, the number one symptoms are either chest, back, or abdominal pain. And then the other symptoms are a little bit more variable and a lot are dependent on whether or not it cuts off blood flow. When it does that ripping of the aortic wall, it can disrupt any artery that comes off the aorta. So people can present with symptoms of a stroke if it's cutting off blood flow to the brain, or really severe abdominal pain if it's cutting off blood flow to the arteries that go to our gut. The important thing to emphasize about acute aortic dissection is the fact that if we know who is at risk for an aortic dissection, in particular those deadly dissections, the type A dissections, we can prevent those dissections. And so we really want to get out the word as to who's at risk for an aortic dissection. Number one is a family history of aortic dissections or aneurysms in the first part of the aorta. And an aneurysm is just where the aorta enlarges, and that tends to be totally asymptomatic. And that predisposes to a dissection. In most people, there's some enlargement of the aorta before the dissection. And that's why we say having that aneurysm there is a risk factor for dissection. The other risk factors are the presence of a congenital heart defect called a bicuspid aortic valve. Other risk factors are there's some genetic syndromes we know that increase the risk for dissection, things like Marfan syndrome. Other risk factors include pregnancy. There's a very low risk of a dissection with pregnancy. And I think much of that can be picked up from the family history. So if you're considering getting pregnant and you have a family history of aneurysms or dissections, you really need to see your doctor before you get pregnant.
So we think that the highest risk time for aortic dissection in pregnancy is typically the third trimester or in the postpartum period. In the third trimester, that's when there is the peak amount of blood pumping around through your body. And in the postpartum period, you've gone through this big stress of having a baby, whether it's via vaginal delivery or a C-section, and there's a big change in the blood that was sort of pumping through the baby just getting dumped back into the mom's circulatory system. And so we think that this third trimester and postpartum is the highest risk time, and when you look at cases, that is when a majority of these cases are happening. We think that hormones potentially could be playing a role. When you're pregnant, you have an increase in hormones such as estrogen and progesterone and potentially oxytocin. And we think that these hormones, when they are increased, could be changing the layers of the blood vessels to make your body accommodate this extra blood, but maybe sometimes that goes awry, and then that can end up in you being at higher risk for a dissection during this time. Unfortunately, in pregnancy, there's a lot of aches and pains as well, and so distinguishing between just a normal aches and pains in pregnancy and aortic dissection is sometimes hard and can delay a diagnosis. If a woman comes in, though, and she has severe chest pain that's not being relieved by antacids or medicines for heartburn, and she continues to have those symptoms, it's definitely important for a physician to sort of think outside of the box and rarer things that could be causing some type of problem. One of those things could be an aortic dissection. If a patient comes in and they have severe chest pain, there's a lot of different things that a physician's thinking about. And usually some of the first tests they're going to order are an EKG and a chest x-ray to rule out some of the more common things that chest pain can be. However, it's important to remember that those are not going to necessarily be able to pick up an aortic dissection, and they'll miss some of the cases.
A chest x-ray will not necessarily give you any information on what's happening inside the aorta. And a dissection is a tear of the inner layers of the aorta. An EKG will not give you information on a dissection unless it's caused a blood flow problem to the heart muscle itself. And that can be misleading too. So to diagnose a dissection, first it requires a good history and physical, and requires people considering it in their differential, and it requires a quick CT scan. The CT scan can actually show you there's a tear there. It's obvious. It's not difficult. There's no diagnostic quandary at that point. Diagnostic work during gestation needs to be carefully balanced with the danger to the fetus and the benefit to the mother. Radiation is minimized during that period to the fetus. It depends on what stage of gestation we're at, but in general, we try and stay away from radiation in the first and second trimesters. In that situation, an echocardiogram, a transthoracic echocardiogram, would be better if you were concerned about an acute aortic dissection. There might be a role for MRI, but the MRI is time-consuming and difficult to get people into the machine in a quick manner. There are situations, though, where we may consider scanning part of the body with a CT scan and shielding the fetus from radiation to make a diagnosis. If aortic dissection is found in a pregnant woman or right after pregnancy, there are a lot of factors to be considered. If it's a type A dissection, meaning a tear of the ascending aorta, no matter if it's during gestation or after delivery, we're going to move quickly to save the life of the mother. If the baby can be delivered, many times we will deliver the baby and then operate on the mother. And that's been a scenario we've done successfully here before. If it's a type B dissection, it can be treated with blood pressure control and then the baby delivered in a timely manner and then the mother treated. We may do that. But it's very specific to the situation. And we need to be focused on primarily the life of the mother, but we're also very focused on making sure the baby has the best chance of life.
I think that going over and talking about aortic dissection is a really important thing for general obstetricians and not necessarily the high-risk doctors, because women can present anywhere. like we talked about before, it's a very rare event. A lot of people may not ever see this in their career, so simulation would be a really great way to add aortic dissection as something that people practice and then sort of know the steps of what they would do and who they would call if someone had an aortic dissection.
My advice to women regarding aortic dissection would be to be your own advocate. If you think you're being dismissed or if you think you're being sent home when something's wrong, stop, refuse to go, tell them something is wrong, you need to do more tests, you need to check me out more, you need to do something, I am not leaving this hospital until you do. If you feel it in your body, and one textbook part of aortic dissection is the impending sense of doom. If you feel that impending sense of doom, do not walk away from that hospital.
I think what I would like women to know about aortic dissection is that, one, it is a scary topic to think about, especially in pregnancy or postpartum, but it's not something to be fearful about. It's something that we learn about other illnesses or things that can happen even to the baby during pregnancy, but we ought to know about things that are regarding the woman's health as well, or risk factors that we may have. I want people to know what the symptoms are if they feel severe chest pain, back pain, or abdominal pain, to not negate that. If you have a gut feeling that something is very wrong, push to get somebody to look at you, to diagnostically check you out, because that gut feeling is there for a reason. And I think that more lives can be saved if we're just aware of the term, aware that it can happen to anybody, no matter your age. It's just something that can happen out of nowhere, just like it did in my case. I feel that I survived for a reason. I feel like I have a purpose in life now to teach people about this rare condition. It is a rare phenomenon, and not every woman will have this happen to them. Not every doctor will ever even see a patient like this in their career. But just to be aware that it does happen, and to tell people about it can save lives.